Okay, while we're waiting to see if there are any questions on the chat, any questions from the audience?
I was wondering, there are many patients that we take care of that have a left SVC to a coronary sinus, and if the thoracic duct may be draining there, we tend to go and coil it and close it in the cath lab. Maybe we should start thinking for the future and leave that connection to the LA as a potential lymphatic decompression.
If I answer?
Yeah, comments?
Yes, but the problem is that most of those patients have heterotaxy. And in heterotaxy syndrome, you can have the thoracic duct to the right. So you have to be sure which way goes the thoracic duct. That is an idea that Mark Gevelig is having, so doing one glen instead of two, and trying to band to have more flow to the side in which you have the glen, trying to band the left or right internal jugular vein at the time of the glen. Never done that, but I think it's good thought.
Yeah, thanks for a great session. The last two were awesome. A question for anyone, because there's really no right answer, just like to hear people's opinions. The idea of biventricular conversion or VAD for delaying transplant obviously come with the risk of increased sensitization in patients who are already sensitized, and then they just wait longer for transplant and may not have options. So how do you guys feel about that conundrum and balance those risks and benefits?
So, yeah, I think the issue of, most transplant centers, I think throughout the country, you have a sick Fontan-Creuser. I think 99% of those patients will end up in the OR table getting a transplant or getting a VAD. If they need it, obviously, we only put VADs in patients who need a VAD, or they're going to die. So we have very little option there. We need to, in some of these patients, they need to be somewhat, the VAD for them might be a way to improve their overall state, before transplantation. So the sensitization piece is real, but, I think we're always in a very tough position when we have to put a VAD on a single ventricle. Okay, but we do it because, we're forced to. The biventricular conversion, I think that there are a lot of patients out there who have a Fontan-Creuser circulation because their anatomy where they were seeing was too complex for the team. And I think a lot of these surgeries require a pretty senior person who's been around the block who is willing to tackle some of these issues that early in your career you're just not ready for them, And I think, at times I remember going to conference and, national conference and seeing patients presented who are single ventricles that I would say that patient could have had a different operation and be biventricular. But I know that in that center, they wouldn't do that operation, and the patient ended up with a single ventricle. So some of those patients might get into trouble and come to institutions like this kid that I presented, and we say, okay, I think we can do this. I didn't present the other patient who, soon after this one, I took to the OR to do the same thing, and unfortunately, I did all the steps, but I just couldn't put an RV to be a conduit on that patient. It just anatomically it was impossible, and I didn't truly appreciate that pre-op. But so I took everything down, fixed everything, and then I had to undo everything, and thank God the patient did okay, and but it's now back on the transplant list. Okay, so at times you have to go on fail, you have to give it a try. At times it's an issue of giving it a try, but these are very difficult patients, and there's no right answer. You do the best you can, and I think every center tries to do the best they can.
Can I say something?
Yeah, go.
The only thing for me that it's not advisable to do is to jeopardize the way of the transplant. Because if you try to recruit a left ventricle and you end up with pulmonary hypertension, then it's not a good idea. So the decision should be made earlier, because I've heard that there are some surgeons around the world that they are doing this reversing the ventricle. So they are doing a double switch, and they will end up with a patient that has a small left ventricle, so probably the compliance for exercise would be bad. And you got a small left ventricle in the pulmonary position, and they will have a right ventricle in the systemic position with a sending and an arterial switch. And probably a sending is one of the procedures that we abandoned because it was full of arrhythmias. So you have a systemic ventricle with a sending, with systemic right ventricle with a sending, and you end up with that because the patient is not even a candidate for a transplant. So I think that the decisions of going to recruit a left ventricle, especially for borderline left ventricle, should be done really early in life. And if you fail, go back and open the ASD and decompress the left atrium. So because this patient probably is going to go to a Fontan pathway, and eventually we will need a transplant.
And you know, the other thing that goes unsaid is that not every country has transplantation as an option. So, I mean, we're sitting here thinking like, well, you put them on the transplant list, but you can't do that.
I can't.
You can't do that. So you have to do all these other surgeries that you know, people might be sitting here and say, well, why did he do that 5 times? Say, because there's really no other option. Right. You know, if you don't try, but those are our realities, and we all have to accept our realities and do the best we can with our reality, you know?
And some patient realities. Some patients, and Matt may comment, they're terrible transplant candidates, right? Whether because they're social issues or whether because they have huge antibodies and they're just not transplant. The wait time would be forever, right?
Yeah, this patient.
I'm wondering about for those complex biventricular repairs, Victor, what do you think, does it help you to have a 3D model to look at the anatomy before to figure things out? Is that something that you think should be done routinely?
I mean, we've been doing that probably for the last few years, certainly for the complex transpose with that get referred, we certainly do the 3D reconstruction, and I think for this really complex biventricular repairs, for sure you need it.
Sasha.
Hi, thank you. First of all, I'd appreciate if I don't have to accept my reality, but we can move on. I remember seeing a video from one of your lymphomaniac friends showing decreased peristalsis, I think it was, of lymphatics in the context of a calcium channel blocker. Has there been any exploration of medications to improve lymphatic function?
Well, that is a question that we have to ask Viveke Hjortal, that has this huge lymphatic laboratory now in Copenhagen. She had a laboratory in Denmark. There are a few medications. Unfortunately, the medications that we commonly use, for example, Lasix, decrease the lymphatic function. And the other thing that Viveke is thinking, and probably I will take the responsibility of speaking in her name, is that every single human being has a different circulatory system. The lymphatic system of every single one of us is different. And some lymphatic systems are able to tolerate much better the high central venous pressure than others. So probably through genomics, we will learn which patients are in danger of a lymphatic complication in the future. And we see, for example, patients that have a Fontan circulation in place for 20, 25 years. We do a T2 MRI, and it looks normal. And we say, but come on, it should be type 4, and it's normal. And we don't know why, because the central venous pressure is high. Another patient with a central venous pressure of 12 has a complete disaster with the thoracic duct very dilated and very tortured. That is an indicator of failure, for example.
But, you know, we were discussing earlier, I think, you know, we do cath in all these patients, but we really don't study their lymphatics pre-op. And one thing is, when they get into trouble, it's okay, you're looking for what's wrong. Mm-hmm. But it'll be more interesting to look at patients, you know, before the Glenn, you do a study, you look at their lymphatics, and maybe for the Fontan, so that we get data about these patients, because we keep dealing with the same. We keep talking about this, which I think is a tremendous concept, and lymphatics clearly are important. And we better put put some, studying into them because, they cause a lot of issues for us. So it's something that, we certainly need to consider here.
And for example, we know that transposition of the great arteries, we used to see a lot of chylothorax, and in pleural spaces that we do not open.
Yeah.
We see that in Down syndrome patients after complete AV canal, we see chylothorax. And probably that is obviously a genetic disorder. Well, that genetic disorder was described, I'm sorry, I forgot the abnormality. But so those patients are keen to lymphatic complications. And probably we are not knowing who are the ones that are going to develop these complications. So I think that can be a game changer for the future.
All right, everybody, thank you for an excellent discussion. That'll be the end of this session. Next is the research highlights.